Hi class, welcome to our first content module. So throughout this course, we'll be using a flipped classroom approach, and I want to take a minute here to explain what that means and how these pre-recorded lectures fit into your learning. So the goal of these videos is really not for you to become an expert before class. Instead, I want you to think of these recordings as your first exposure to the content. They're going to provide a brief overview of the diseases and disorders we'll be studying so that you can come to class with a basic understanding of what's happening. And in each pre-lecture, we're going to consistently review 4 key concepts. So the pathophysiology, what's happening inside the body, what normal processes have changed to produce the disease, and then risk factors and causes, so who's most likely to develop the condition and what contributes to it, clinical manifestations, or what signs and symptoms you would expect to see during your assessment, and then diagnostics, or how the condition is identified or confirmed. And you'll notice that we're going to intentionally stop there. We're not going into great detail about the treatment, medications, or nursing interventions during these videos because that's what we're going to work through together during class. So when you arrive in class, we're going to build on this foundation by applying what you've learned through patient cases, clinical scenarios, and active learning activities. And we're going to discuss nursing priorities, interventions, patient education, and clinical judgment. Essentially, we're answering the question, now that we know what the disease is, what does the nurse do? And my expectation isn't that you've memorized every detail before class. Instead, I really want you to watch the video before class, take some notes, become familiar with the terminology, and identify anything that doesn't quite make sense yet. It's completely normal if you don't understand everything the first time you hear it. Learning in nursing happens through repetition and application, and you'll hear the concept in these videos first, and then you'll practice applying them in class. Reinforce them during lab or simulation when appropriate, and then you'll revisit them again while you're studying for the exams and eventually caring for your patients. So as we move through the semester, you'll notice that every disease follows a similar pattern. So if you can answer these 4 questions, so what's happening in the body, who is at risk and why, what assessment findings should I expect, how is it diagnosed, you'll have a strong foundation for understanding why we choose certain nursing interventions later. So let's get started with our first group of disorders, which are upper respiratory disorders. And before we jump into the content, I want to spend a minute talking about these learning objectives because they're much more than just a list at the beginning of each lecture. One of the biggest mistakes nursing students make is trying to memorize every single fact from every PowerPoint slide. That approach usually leads to feeling really overwhelmed, and it honestly doesn't prepare you for NCLEX, our exams, or clinical practice. Instead, I want you to use these learning objectives as your study guide. And as you're watching these videos, attending class, or studying for an exam, come back to these learning objectives and ask yourself, can I explain this objective without looking at my notes? If you can teach it to someone else in your own words, you're probably ready. For example, our first objective says that you'll differentiate normal and abnormal respiratory findings. So as you're studying, we're not just memorizing lists of symptoms. Instead, we're thinking about what findings are expected versus what findings should concern you. So let's say a patient presents with a sore throat and runny nose. Those are really common manifestations of a viral upper respiratory infection and are often expected. But what if the same patient suddenly develops difficulty swallowing, drooling, muffled voice, or stridor? Those are abnormal findings that suggest the airway may be compromised and require immediate evaluation. Or we can consider a patient with pharyngitis. Mild throat redness and discomfort are expected. However, unilateral throat swelling, deviation from the uvula, or inability to open the mouth fully could indicate a paratonsillar abscess, which is much more serious. So as you're studying each disorder this semester, don't simply ask what symptoms does this disease cause. Instead, ask yourself which findings are expected and which findings tell me my patient is getting worse. That's clinical judgment, and that's what you're going to be using both on our exams, on the NCLEX, and in practice. Our second objective focuses on using nursing process. So as we discuss each respiratory disorder, I want you to continually think like a nurse. What assessment findings would I expect? What should I monitor? What nursing interventions would be appropriate? What patient education is important? Who would I collaborate with? And notice that we're moving beyond memorization of symptoms. We're applying this knowledge, what you need to know to care for your patient. The third objective asks you to compare and contrast respiratory diseases. So rather than studying each disease in isolation, we're looking for patterns. So for every disorder, you're asking yourself, what causes it? What is happening physiologically? What are the hallmark signs and symptoms? How is it diagnosed? How is it managed? How is it different from other respiratory conditions? And you'll notice that many diseases follow a similar framework, and recognizing those patterns makes studying so much easier. And finally, the last objective reminds us to recognize complications. And as nurses, we don't just identify disease, we identify when the patient is getting worse. So as you study each condition, you're asking yourself, what is the most serious complication? What assessment findings would alert me that my patient is actually deteriorating? What would I do first as the nurse? Those are the types of questions you'll see on our exams, on the NCLEX, and what you will encounter in clinical practice. So throughout the semester, I encourage you to come back to these learning objectives often. Don't just read them on the first day and forget about them. Use them as a checklist to guide your studying. If you can confidently answer each objective by the end of the unit, you'll be much better prepared, not just for the exam, but for caring for patients as a future nurse. So let's take a quick look at what we'll be covering in this module. We'll begin with a brief overview of the upper respiratory system and then discuss common upper respiratory infections, followed by pharyngitis, tonsillitis, epistaxis, and finally obstructive sleep apnea. Remember, these pre-recorded lectures are designed to give you a foundation before we meet in class. So for each disorder, we're going to follow the same framework. What's happening, so the patho, who is at risk and what causes it, so the risk factors and causes, what would you expect to see, clinical manifestations, and how is it diagnosed, or diagnostics. So again, that's intentional. We're not diving deep into treatments or nursing interventions yet, because we'll spend our class time applying these concepts through case studies, clinical scenarios, discussions, where we're going to develop more clinical judgment. I also encourage you to take advantage of every learning resource available to you. These lectures are just one piece of the puzzle. So be sure to read the corresponding textbook sections outlined in the syllabus. Watch the supplemental videos that are posted. Review diagrams and illustrations if that's how you learn, by looking at pictures. Practice explaining the concepts in your own words and come to class with questions. Research consistently shows that students retain information much better when they're exposed to it multiple times and in different ways. So the more you immerse yourself in the material, the stronger your understanding is going to become. One piece of advice I'd like to leave you with is this: treat learning nursing like it's your profession, because one day it will be. So the habits you develop now are going to carry you into clinical practice. I've had many students tell me after a course or even after graduation, I wish I had started studying earlier, or I wish I had used all the resources that were available. So my hope is that you don't have that hindsight. Manage your time intentionally, stay engaged each week, and use the resources we provided. Small, consistent effort throughout the semester is much more effective than trying to cram everything in at the end. If you do that, you'll not only be more successful on your exams, but you'll also build the knowledge and confidence you'll need when you're caring for real patients. So before we discuss specific upper respiratory disorders, let's briefly review how the respiratory system is organized. Respiratory disorders are some of the most common conditions you'll encounter as a nurse, whether you're working in primary care, the emergency department, the hospital, or long-term care. Nearly every patient you care for will have some component of a respiratory assessment, so understanding the anatomy and function of the respiratory tract is essential. Although we often divide the respiratory system into upper and lower respiratory tracts, it's important to remember that they are functioning as one continuous system. So a problem in one area can affect the other. For example, a simple upper respiratory infection may remain localized to the nose and throat, or it can progress into a lower respiratory tract infection, developing into bronchitis or pneumonia in susceptible patients. The upper airway includes the nose, paranasal sinuses, pharynx, tonsils, adenoids, and larynx. So for today's lecture, we'll also include the trachea as part of our discussion because it serves as a transition between the upper and lower airways. And the primary functions of the upper airway are to filter inhaled particles and microorganisms, warm and humidify inspired air, protect the lower respiratory tract from infection and foreign material, facilitate speech, swallowing, taste, and smell. And the lower airway includes the trachea, bronchi, bronchioles, alveoli, lungs, and pleura. And this portion of the respiratory system is primarily responsible for moving air into the lungs, allowing for gas exchange to occur. Ultimately, the respiratory system has four major functions: ventilation, which is the movement of air into and out of the lungs; respiration, which refers to the exchange and use of oxygen and carbon dioxide at both the lungs and the cellular level; gas exchange, where oxygen diffuses into the bloodstream and carbon dioxide diffuses out to be exhaled; and oxygen transport, where oxygen is carried by hemoglobin to the tissues so cells can produce energy. So as we move through the respiratory unit, I want you to continually ask yourself, where is the disease occurring? Is it affecting the upper airway, where you might expect symptoms like nasal congestion, sore throat, or hoarseness? Or is it affecting the lower airway, where patients are more likely to experience cough, shortness of breath, abnormal lung sounds, or impaired oxygenation? So keeping that anatomical framework in mind will make it much easier to understand the patho of each disorder and recognize when patients present the way they do. So starting with upper respiratory infections, or URIs, these are infections involving the structures of the upper airway, including the nose, sinuses, pharynx, and larynx. And these infections are extremely common, one of the leading reasons patients seek health care. And fortunately, most URIs are viral, meaning antibiotics are not effective, and treatment is generally supportive. But there are times when they can be bacterial, so we need to pay closer attention with more severe symptoms. URIs, the patho here begins when virus enters the body through respiratory droplets or direct contact with contaminated surfaces. And the virus attaches to the epithelial cells lining the upper airway, and it begins to replicate. So as the immune system responds, inflammatory mediators are released, causing vasodilation, increased mucus production, and edema of the mucous membranes. And these inflammatory changes produce the familiar symptoms of congestion, rhinorrhea, sore throat, and cough. So most viral infections remain localized to the upper airway and resolve within 1 to 2 weeks as the immune system clears that virus. Risk factors and common causes. The most common cause of URIs is a viral infection, and some common viruses include rhinovirus, which is the most common cause of the common cold, influenza virus or coronavirus that may cause common cold illness. Several factors can increase a person's risk for developing a URI, which include close contact with infected individuals, such as in schools or healthcare settings, poor hand hygiene, smoking or secondhand smoke exposure, which impairs normal airway defenses, extremes of age, so especially young children, and then on the opposite end of the spectrum, we have older adults, chronic illnesses or immunosuppression, and then seasonal increases during the fall and winter months. Clinical manifestations. So because inflammation occurs in the upper airway, patients are commonly presenting with runny or stuffy nose, so rhinorrhea, sore throat, cough, sneezing. Some additional findings may include mild fever, fatigue, hoarseness, postnasal drainage, mild headaches, and symptoms usually develop gradually over 1 to 3 days and improve without complications. Then diagnostics, the diagnosis of a URI, it's primary clinical. It's based on the patient's history and physical exam. So during the assessment, nurses should evaluate the onset and duration of symptoms, if they have any fever and the pattern of the fever, nasal drainage characteristics, throat appearance, presence of a cough, any exposure to sick contacts. Usually routine lab testing, it's not typically necessary for uncomplicated viral urinary upper airway infections. I don't know why I said urinary. Anyway, however, depending on the symptoms and clinical suspicion, providers may order rapid influenza testing, COVID-19 testing, sometimes even rapid streptococcal testing if bacterial pharyngitis is suspected. But the primary goal of the assessment is to distinguish a simple viral URI from a more serious condition, such as bacterial sinusitis, streptococcal pharyngitis, pneumonia, or epiglottitis that require different kind of management. Now let's discuss pharyngitis. This is one of the most common upper respiratory conditions encountered in primary care. And the pharyngitis is inflammation of the pharynx or the throat. So the inflammation occurs when infectious organisms or irritants trigger an immune response within the pharyngeal mucosa. Most cases, approximately 70 to 90% in adults, are caused by viruses. Some common viral pathogens include that rhinovirus again, influenza, adenovirus, and Epstein-Barr virus, which causes infectious mononucleosis or mono. Less commonly, pharyngitis is caused by bacteria. So with group A, Streptococcus, also known as Streptococcus pyogenes, being the most important bacterial cause because it requires antibiotic treatment to prevent complications such as acute rheumatic fever. So strep throat can lead to rheumatic fever. And as inflammation develops, the blood vessels within the pharynx dilate and become more permeable, and this results in erythema, edema, pain, and increased sensitivity, making swallowing uncomfortable. And in bacterial infections, neutrophils accumulate and it may produce purulent exudates or white patches on the tonsils. Some risk factors and causes. So although viruses are responsible for most cases, several factors increase a person's risk of developing pharyngitis. So things like rhinovirus, influenza, adenovirus, Epstein-Barr virus, group A strep. Some non-infectious causes include seasonal allergies, dry air, cigarette smoke or vaping, environmental irritants such as pollution, and then gastroesophageal reflux disease or GERD, which can chronically irritate the throat. Other risk factors include school-aged children, adolescents, particularly for Streptococcus pharyngitis, close contact with infected individuals, crowded environments such as schools, dormitories, or daycare centers, smoking or secondhand smoke exposure, and then weakened immune function. Clinical manifestations, patients most commonly present with a sore throat, painful swallowing, red, swollen pharynx. Sometimes additional findings may include fever, headache, fatigue, tenderness, or enlarged anterior cervical lymph nodes. And assessment findings can also help us distinguish between viral from bacterial infection. So for viral pharyngitis, it often occurs with a cough, runny nose, hoarseness, sometimes conjunctivitis. And these symptoms are generally not present with streptococcal pharyngitis. In group A streptococcal pharyngitis, patients are most likely to have sudden onset of severe sore throat, fever, tonsillar exudates, tender anterior cervical lymphadenopathy, and absence of a cough. So these findings increase the suspicion for bacterial infection and are going to help guide diagnostic testing. For diagnostics, diagnosis begins with a thorough history and physical exam, and during the assessment we're going to evaluate the onset and duration of symptoms, any presence of fever, difficulty swallowing, any exposure to individuals with strep throat, associated viral symptoms such as the cough or nasal congestion, and then our physical exam includes inspection of the pharynx for erythema, tonsils for enlargement or exudate, cervical lymph nodes for tenderness and swelling. If group A strep is suspected, a rapid antigen detection test is commonly performed, so that rapid strep test. If the if the rapid test is negative, a throat culture may be obtained because it remains the gold standard for confirming streptococcal infection. If the patient does have a sore throat that persists for more than a week and complains of profound fatigue and significantly enlarged lymph nodes, especially in the posterior cervical chain along the back of the neck, the healthcare provider may begin to suspect infectious mononucleosis, commonly called mono. So mono is caused by the Epstein-Barr virus. It's most common in adolescents and young adults. And unlike patients with routine viral pharyngitis, patients with mono often describe feeling completely exhausted, and that fatigue may last for several weeks or months. So to help distinguish between mono and viral pharyngitis, providers may order an antibody test, commonly known as the monospot test. This blood test detects antibodies that the immune system produces in response to the Epstein-Barr virus infection. So it's important to remember that the monospot test may be negative during the first week of illness. So if clinical suspicion does remain high, so the patient continues to have symptoms, the provider may repeat the test later or order EBV-specific antibody testing, which is more sensitive, and it can distinguish between a current and past infection.